I think we're good to go. Let me screen. Okay. All right. As we discussed yesterday, so what we did yesterday is we defined what abnormal psychology is. And we went through the different ways abnormal behavior and mental processes have been viewed or seen. We saw that it's a combination of culture, our community, and our individual perceptions. We went through how, from at least maybe a scientific perspective, we can define abnormality by using statistical methodology, which we'll get more into when we get to the DSM, um, and how that is used to define what a disorder is and what is not a disorder. We also recognize that there's a difference between mental health and mental illness, just like there's a difference between physical health and physical illness. And noted that you can have really good mental health, but can still end up having a mental disorder of some type. Just like you can have very, very poor mental health and not meet the criteria or what would be defined as a mental illness. But as we did finalize that, we did mention that just like poor physical health, poor mental health does increase the probability of ending up with some type of psychological disorder. So that's kind of where a summary of yesterday. And what I want to get into at the beginning of this class is the role of trauma. Okay. Trauma usually can be defined as an unexpected event that is often negative in nature. So we could see go anywhere from the sudden death of a parent or a loved one to a horrific car accident to on the battlefield with combat military individuals. We can go into things like domestic violence and sexual assault. So any type of event that then creates some type of traumatic response. Okay. Now, what we want to look at is how does trauma influence our physical health and mental health? Because again, we can have a trauma response, but that doesn't necessarily mean that we'll end up with, for example, a mental illness or even a physical illness. On the flip side of that, as I mentioned with the mental health, mental illness talk yesterday, we could have no trauma and still experience some type of mental illness. And we'll kind of try and clarify and tease those things out as we move along. But let's first talk about what is for what we call a post-traumatic response symptoms. Okay. So first we're going to define this because a person can have post-traumatic response symptoms but not necessarily have post-traumatic stress disorder, which again is kind of the analogy between mental health and disorders and mental disorders. Okay. But post-traumatic response symptoms occur as a reaction to experiencing or witnessing a traumatic event. These symptoms can affect our emotional, psychological, and physical functioning. Okay. And they're often associated with post-traumatic stress disorder. Again, when we go back to the difference between having symptomology and disorder, disorders are persistent over time. They become maladaptive to the individual. But a lot of times, symptoms or responses to trauma can be negative in nature, but may not necessarily end in a disorder of some type. Okay. So causes are triggered by events such as accidents, natural disasters, abuse, and combat. And we should note the difference between acute trauma versus chronic trauma. Okay. We didn't talk much about this in the human development section, but there is something called ACEs. Okay. And they are an accumulation of childhood, basically traumas that accumulate over time and negative experiences that accumulate over time that then influence the child's mental health as they grow and develop. Okay. Um, and this is an example of what we call the influence of chronic trauma or ongoing continued trauma and how it can influence a person's life. We do note that chronic trauma does result in more negative outcomes if it's not treated. But acute trauma can also have very negative influences on an individual. And acute trauma would be something like a natural disaster or being involved in some type of accident, whereas chronic trauma includes things like ongoing abuse in the home or even combat, going on several missions in a combat zone are all examples of chronic trauma. Okay. And as you could probably note, it can last. The symptoms of post-traumatic stress or post-traumatic events can last anywhere from weeks to months. And for when it goes from the symptoms to the disorder, it can last for years. Okay. Um, and so most commonly, about 17% of individuals who experience some type of severe acute or chronic trauma will end up with post-traumatic stress disorder. And I should say there's more conservative numbers. The conservative numbers is anywhere from about 13 to about 17% of individuals. So in our class of that we have here of 10 individuals, if we all experience some type of horrific trauma event, there's 10 of us, so about 2 of us have the probability of ending up with post-traumatic stress disorder, which can last months, if not even years. So that's kind of the breakdown. The 8 out of 10 of us would maybe experience the symptoms of that trauma for a couple weeks to a couple months. Couple months, I'm saying 6, 8, 10 months, possibly, and I'll get into that a little bit more later. But that's kind of the duration of many trauma responses. Okay. Now, we should go through so these are some of the responses. This is some of the symptoms. And if you notice, it's broken up into 3 categories: our emotional system, our psychological systems, the way we think, the way we see the world, the way we focus on the world, and behavioral symptoms. Okay. The ones that you see with check marks by them are the most common. Okay. The ones that don't have a check mark on them, there's some debate on their development. Okay. And I'll kind of get through those. But the most common symptoms of emotional symptoms include fear and helplessness and guilt and shame. Okay. Um, and so in this arena, the other thing that I want you to pay attention to the check marks is here in a moment, we're also going to talk about what is called historical trauma. Okay. The ones with the check marks are also very common symptoms of individuals who have a very condensed period of historical trauma. Okay. Um, so that's the other side of it. Okay. With the emotional symptoms, you can also experience anxiety and depression. Okay. Anxiety is unwanted worry about something. The very simple definition. Depression is reduction in mood and motivation. Okay. In the psychological symptoms, very common, especially with combat and relationship violence and sexual violence, are intrusive thoughts and flashback nightmares. Those are very, very common. But also with acute, intensive traumas. I worked with a young lady who witnessed a car accident where an individual was decapitated. Okay. And she wasn't involved in the car accident. She was just a witness, but she saw the person's dismemberment from her car. And intrusive thoughts and flashbacks and nightmares were a very, very common thing for her because of the intensity of that type of one time trauma. But these are also very, very common for individuals who get out of abusive relationships or come back from a combat zone. Usually they start to occur about 6 to 9 months post leaving those trauma zones. Um, and those tend to be very intrusive into their lives. Okay. But right away, usually, very common is the hypervigilance and difficulty in concentrating. Okay. This hypervigilance, if we want to trace it back to biological causes, is we have a heightened level of stress hormones in our body when we've gone through trauma. And when we don't do something with those trauma symptoms, those stress hormones can continue to be present in the system and continue to be produced. One of the stress hormones is cortisol. Cortisol ups the level of hypervigilance within the limbic and brainstem area where you have this need to be very um, 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 vigilant, very almost like you drank 10 cups of coffee and you just can't stop focusing and being wary. If you look at a lot of, for example, this is why, for example, a lot of individuals who have combat post-traumatic symptoms, and to some degree, individuals who have been abused, this is why they go into a restaurant and they have to sit in a position where they can see everything that is going on. Okay. The other common symptom is, of course, difficulty concentrating. This does go back to the stress response because those cortisol levels decrease the frontal cortical activity of our brain because our body is put into a survival mode. And so without that, and when our brain does go into survival mode, much of the energy and everything within the brain goes from the higher cortical areas into the limbic areas, which then make it very difficult to concentrate. And this is why a lot of people who have post-traumatic stress very much focus on survival and just surviving from day to day. Okay. Behavioral symptoms, of course, probably the number one is avoidance or reminders of the triggers. And we often find a lot of social withdrawal from individuals. Some other very common ones are irritability and aggression and substance abuse. Okay. And I will stop here at substance abuse for just a minute because I mentioned in that previous slide that trauma is often associated with the onset of other disorders, okay, such as substance use, such as other disorders such as anxiety and depression. They are very common co-occurring symptomology. Okay. And it's often, when it comes to substance abuse, it's often used as a self-medication to deal with a lot of these trauma symptoms. Okay. When it comes to other disorders, okay, is that usually when we see someone develop stuff like anxiety or depression because of some trauma response, it's often because they have a genetic predisposition to those disorders, and the trauma triggers the genetic response to that disorder. Okay. And trauma can even trigger things like psychosis. One of the leading theories of schizophrenia, for example, which schizophrenia is denoted by delusional thinking, incoherent ability to follow stories, most commonly is associated with hallucinations, those types of things. One of the most common theories is that most individuals who have schizophrenia develop it between the age of about 18 to 22. And it's believed that it's because of the individual leaving the house. Most individuals who develop schizophrenia, it's usually within 6 months to a year after leaving their home, their childhood home. And it's thought that maybe the trauma of being out on your own, being independent, and all of those things might trigger those genetic predispositions to that disorder. So that's one of the theories. We'll get to schizophrenia here in the next couple of days, probably Thursday or maybe Monday. But that's one of the theories about why the majority of individuals get late onset schizophrenia, usually between about the age of 18 to about 22. Okay. Now, that's not everybody. So it doesn't beat everybody's narrative, but just keep that in mind. Okay. Now, it's also important just to remind everybody that you can get a disorder without a trigger. So there's some people who are at the pinnacle of success and happiness, and the next day they might wake up with complete symptomology of depression or anxiety or even psychosis. So trauma is not the only way to trigger dispositions to certain disorders. So I do want to put that out, but it's a very common one. Okay. So I want to talk just a minute. So this is lived trauma. What we've been talking about is lived trauma. So the experience of trauma within your lived life. Okay. There is also something in a growing literature about what is known as historical trauma. And it's been commonly studied, especially among Native American groups. Okay. So I'm just going to read the definition and everything. So historical trauma refers to a cumulative emotional and psychological wound across generations caused by traumatic events experienced by a group. For Native Americans, this includes colonization, forced removal, cultural suspension, suppression, and systematic discrimination. Okay. The impact of this type of trauma is in mental health challenges, loss of cultural identity, social economic struggles, and disruptions in family and community structures. So I just want to pause here for just a minute because I've given some talks on historical trauma and Native American populations. And the most common question, especially coming from non-Native individuals, is they will say, every people's, everyone, even European white people, during the course of their history, their people have experienced trauma. And of course, the white Europeans will say, you know, you look at the battles between the European countries, the fall of Rome, the Greek wars, more modern times, you know, you can think of the development of countries, and they even argue the process of colonization. For example, the um, Civil War here in the United States, wouldn't that be considered part of historical trauma that then develops into a person's psyche? Okay. And I want to make it clear, why is it that a lot of focus is put on Native American historical trauma? Is yes, anyone who lives on this earth has genealogy in them that has experienced some type of trauma, but normally that trauma has happened over millennia. Okay. When we talk about Native American trauma, historical trauma, it has happened over a very condensed period of time. It's literally happened over just a 500-year period of time. And that condensed trauma then has had a larger influence on Native Americans' lived experiences now. Okay. So, why is it talked so much about in Native American communities versus other communities? It's because it has happened in such a condensed period of time. It's not something, yes, there was warring factions before colonizations. Yes, there were battles between and whatnot here on this continent, but none that was so traumatizing and met the level of death and destruction as colonization, forced removal, cultural suppression, and systematic discrimination. Okay. There are other groups, yes, that have similar histories, but this is what makes historical trauma among Native American groups so impactful on the lived experiences that are very common among Native American communities right now. Okay. So when we look at this, we also have to recognize that there's a growing body of evidence, and I do want to say this with caution, that especially among Native American groups, that this seems to be being passed on from generation to generation on a genetic level. Okay. There was a study done, I believe, 2017. It was either somewhere between 2017 and 2019, where a researcher did find some genetic markers of historical trauma and how it is transmitted from one generation to the next genetically. Okay. I say this with caution. There's a growing body of evidence, but we don't have any replications of those studies. So I'm waiting to see if those studies are replicated. I haven't seen any replications yet, but I have been seeing still this growing body that even this historical trauma not only is transmitted through our stories, the way our community tells the history of the people, but also it is being carried physically, potentially, from one generation to the next. Okay. So compounding this effect is trauma severity. Okay, so this is how much how much trauma will interrupt their life. Okay, so the severity, when we think about this from especially a Native American perspective, is we can put it in kind of this quasi um, equation. is trauma severity. How much trauma can influence a person's ability to function and live healthily? This little f right here means function. So this means, and then the parentheses means function of, okay? So it's a function of historical trauma, the things we carry from the where we come from, and lived trauma, okay? So it's the combination of the abuses, the violence, possibly the losses that we have in our lived life, plus what is carried along with us through our history. And then that is tempered by resiliency. Okay. Resiliency on an individual level is how much the individual can manage or deal with the trauma that they're living. Can they deal with it in a proactive way, or or do they not have the coping skills to deal with those that compounded trauma? And on the more community level is what has the community done to develop healthy communities, invest in healthy family systems, and promote things like cultural identity and language and all of those types of things. Okay, so those are the resiliency factors. Without those resiliency factors, we found that both the combination of historical trauma and lived trauma can increase the impact it has on an individual. Okay. So I do want to just really quickly stop here and just see if everyone is okay. Does anybody have any questions on what we've gone over so far? You can put it in the chat. You can unmute yourself. You can raise your hand. All right. Thank you, Michael. Okay. All right. So I want to just talk really quickly about some of the resiliency factors that have been found to, at least in studies, been able to help communities and individuals deal with, or I shouldn't say deal with, um, manage and overcome both the effects of historical and lived trauma. Okay. And there's about four of them that have been found, especially in the field of education. One is cultural responsive education. So this is incorporating Native American history, culture, and perspective into curriculums. Okay. And that's one of the, you'll notice one of the major goals of TOCC is to make sure that culture is very much recognized a part of all of our curriculum. Okay. The second one is something called trauma-informed practices, and that's recognizing and responding to the effects of historical trauma and creating supportive, understanding, and safe learning environments. Okay, trauma-informed practices is all about setting up a safe environment for which people can express themselves. And this can be from early childhood clear up into college level or even employment settings where people feel safe and are able to express who they are as individuals. Okay. Community engagement, collaborate with Native communities and integrate traditional knowledge, language, and practices into education. And promote resiliency, focus on strengths, fostering positive identity development, and empower students through leadership and advocacy opportunities. So these are all ways, at least if you're going into education or maybe the helping fields, these are four ways that have commonly been considered kind of best practices. Okay. All right. So that's okay. So that's the what I wanted to go over with trauma, and if we had a lot more time, I could go into it in more detail, and really talk about it a lot more. But what I want us to understand from a introduction to psychology perspective is that trauma depended upon the person's ability to respond to it can have negative consequences on the individual's well-being. Okay. And at the beginning, you'll notice that this is trauma's effect on um, on physical and mental well-being. Often people think trauma will only affect you mentally. It will quote unquote screw up your head. It'll make you think differently. It'll do all of those kinds of things. But we're actually finding more and more evidence that it actually has a compounding effect on your physical health. In fact, it's been associated with things like the development of type 2 diabetes. It's been associated with different changes in our immune system responses. It actually weakens our immune response. Okay. And so not only does it have an influence on our psychological well-being, it also has an influence on our physical well-being. And this is kind of why I want to start with this, because it is one of the larger culprits leading to things like psychological disorders and mental illness. Okay. And so I just wanted to kind of bring that up at this point. But what I'd like to do with the last few minutes of our class today is start in on the history of abnormality or mental disorders. Okay. Mainly the main goal behind telling this story is to show why through much of our history, having a mental illness was kind of a shame for a lot of people. And even today, I always liken this to, we're seeing it a little bit more and more, for example, especially with childhood disorders and what's not, like autism and whatnot, is I don't see a lot of people. We see a lot of people wearing the breast cancer shirt with the breast cancer thing, and people saying, I survived heart disease. And those types of things. I survived breast cancer or prostate cancer. We see those kinds of shirts and posts on social medias, but we don't often see things like I suffer from schizophrenia, but it's in remission, or I suffer from depression, but I'm having it treated, or it's being where I'm getting it treated. You don't see that very much. Maybe a few little corners of our social world we see that, but not very many. And I want to kind of show where that comes from a very historical perspective. Okay. And the best place to start is what is known as moral corruption theory. This theory is that people with mental illness lack moral fortitude. They lack hardiness. They lack the inability to resist temptation. In fact, one of the earliest theories of mental illness is that the person was, and this is where the term thin skin comes from. So when you mention someone that has very thin skin, it was believed that a person who did not have a strong moral base they actually had holes in their spirit that allowed bad spirits to come and influence their ability to exist. And this is where the idea of being thin skinned comes from. Okay. And so I'm going to give a very, very short history, and this is a truncated history on some of these ideas behind the moral fortitude theory. Okay. And we're going to start with something known as trephining. We'll go through some theories, some other theories about it, and banishment and witch hunts. But it's going to be a kind of a very truncated, kind of shortened history. I would encourage you, if you find some of this interesting, to kind of do more of a deep dive into these topics. So early theories, and we find these across cultures, is that abnormal behavior or mental illnesses were caused by evil spirits. Okay. And it was evil spirits, and the goal was to release these evil spirits from the individual. Okay. And you'll notice I have two graphs here because I want to note that these theories are a couple thousand years old, and they have occurred across cultures. We have evidence of trephining here in the Americas, the Asian countries, and in Western societies. Okay. And what trephining is what they do is they drill a hole at the very top of the head. Okay. And the belief is that by drilling the hole at the very top of the head, it will release the evil spirit and will let the evil spirit go. Okay. Now, was this effective? And there's two areas of investigation we need to go into. From the behavioral observation perspective, it was a very effective treatment, but it's not for reasons of healing and curing. It's because, from a behavioral perspective, if you open up the cavity of the brain, which has no natural immune systems within it, it becomes very quickly infected, usually with gangrene or something like that. Okay. And if you have then an infection of that type, not only are you focusing on being depressed or anxious or having psychosis, you're completely and totally lethargic, meaning that your symptomology went away. You were no longer being psychotic, usually because you were near death. The other part of it is shortly after this trephining occurs, the person usually passed away, which is further evidence for its efficacy, because not only did you get that evil spirit away from that person, but that you then sent that individual to God. That person then passed on to God for further healing from that possession of that evil spirit. Okay. So was it an effective treatment? Absolutely. The person stopped having hysterical, psychotic symptoms. They were released from the evil spirit, and they were then usually eventually sent to God or whoever, the great spirits of the world, and their suffering had ended. Okay. Now, I do want to mention trephining did actually end up being something that ended up being very positive. In fact, trephining was very often used clear up through the Vietnam War era. Okay. And it was usually what they found on the battlefield is people who had a post-traumatic, not post-traumatic, traumatic brain injury, something that hit the head. When someone is assaulted in the head region, it's not usually the assault that kills the person. Usually what happens is that the assault hits the head, so something hard hits the head or they get banged really hard. And it's actually the brain swells and squishes itself inside the skull that results in brain injury, then resulting in death, especially on the battlefield. While using trephining, they actually found that the survival rate from traumatic brain injuries increased because what it did is it allowed the brain to swell outside the skull. Okay. So this was a very common treatment clear up through the Vietnam era. You had someone with traumatic brain injury, you drilled a hole in the top of their head, you let their brain swell out, you sent them to the hospital for the remainder of the treatment. Okay. Now, in modern times, this isn't commonly used anymore. Usually, what they do on the battlefield now is they just basically put the individual in a giant ice pack and they pack their head and they shoot them full of anti inflammatory medications. Trephining is probably, I don't know, very commonly used in at least American armed forces, but it was used clear up through the Vietnam era when people got traumatic brain injury. So it did end up in a medical procedure that then was applicable in the survival rate with traumatic brain injuries. Did it cure mental illness? That I would say no, other than the person no longer suffered from it after they passed away. Okay. And this is, I'm not going to play this. This is an example of modern trephining, but I've been told it's too traumatic, so we'll skip that. I do want to mention that our ancestors didn't always necessarily result to a moral or a religious reason behind mental illnesses. Okay. Even here in the Americas, it wasn't always based. There's a lot of, for example, in the Tana O'odham Nation, a lot of the explanations for individuals who ended up acting abnormally is because the community wasn't doing their job. They weren't helping the person survive and thrive. Okay. Yes, there are spiritual stories as well, but in each society, there is a balance, sometimes a balance between what are called naturalistic theories versus spiritual or religious theories like the corruption theory. Okay. And so I kind of want to go over two because they both kind of influence even modern thought today. Well, actually, one, but they're related. And that is the Greek humor theory. Okay. When you tell someone that they are being humorous, you're telling them that their body fluids look good. If you're telling someone that they have a really bad humor about them, you're telling them that there's something wrong with their body fluids. Okay, because this is where the term humor comes from, is a Greek theory of the humor system of mental health. Okay, what the Greeks believed, and they related it to, of course, earth with being with bile, fire being with bile, air being with blood, and water being with phlegm. Um, and they put them on this hot, moist, cold, dry continuum. Okay. But let's say you had black bile. This meant that you were melancholy or sad. If we were to put it in modern terms, it would mean that you have clinical depression. Okay. If you had, for example, yellow bile, it meant that you were bad tempered or you were easily angered or easily whatnot. If your blood was good and red, it meant you were optimistic and positive. If you had a lot of phlegm, it probably meant that you weren't working very hard, you lacked motivation, you probably were very unemotional. Okay. And it was believed that, again, going back to even some of the thoughts in the American systems going historically, is that all of these things needed to be in a balance in order for someone to be psychologically okay. So you had to have all of these elements, your blood, your body fluids, they all need to be in a good balance. And you tell that by the color or the consistency of each of these different four humors. Okay. This led to one of the most popular treatment for especially things like psychosis or manic individuals, people who are being very manic, okay, people who were criminally based and aggressive, okay. This led to something called bloodletting, all right. Bloodletting is where you basically laid on a table and that table had a drainage underneath it. And the individual would stick a huge needle in the person's back or into a vein and let blood out until the person was no longer being manic. Okay. And the idea is that you were letting the bad blood out of the individual until they no longer were having the manic or manic phase of of what they were going through. Okay. Did this work? And this kind of goes back to our example of trephining. The answer is from observation, it did. The person stopped becoming manic, they stopped becoming psychotic and aggressive, but it probably was not for the reasons that it was because they were letting bad blood out. Usually they drained enough blood that the person was actually on the urge of death. They were almost at the they drained enough that the person was barely alive, and so they were usually very lethargic, very immobile. And so, aha! If you're a doctor, then you go, aha! They're no longer being manic or psychotic anymore. The treatment worked. Okay. All right, I want to talk about modern things that this theory led to. First of all, please do not think we have left the humor theory of health, okay? Because I am willing to bet that if you go to the doctor and you're claiming about some symptoms of some type, they're going to have you pee in a cup, poop in a cup, or they're going to take some blood. They're going to put it in a machine that's going to twist that blood or whatever around and around and around, and it's going to spit out all these numbers. And the doctor is going to come to you and say, well, based on your blood, we think you have this. Okay. So the Greek humor theory has not actually left us. I'm hoping what we have done is we refined it to a level using science and whatnot, that we're actually using our bodily fluids to actually tell us that there's something wrong with us. But the reason why we do blood tests and urine tests and all of those things goes back a couple thousand years to this Greek humor theory. So that has followed with us, at least in Western medicine. If you want to think about it that way, you can go in and say, yeah, that's going to be humorous as you take my blood out when you get your blood taken. Okay. On the bloodletting end, one of the things that it did lead to in the 17th and 18th century is what was known as cathartic release. Okay. This is the belief that what holds a person manic or angry and stuff is because they hold things inside until they get to a point, kind of like a shaken soda bottle, that all of that pressure just needs to be released. Okay. And this is known as cathartic release. It came from the bloodletting tradition, but then it became more of an emotional release instead of a physical blood release and whatnot. And so, and this has influenced a lot of things like anger management training, people who go through manic phases, and all kinds of things. I actually read a review of anger management, and cathartic release is still recommended at least in about 20% of anger management programs. Okay. Okay. Does cathartic release work or not? Okay. The answer is that it depends. Okay. When we look at treatment for anger, for example, anger management, we actually have found that cathartic release increases aggression. It doesn't decrease aggression, meaning that when you just let someone express all of their anger, all of their emotional anger and whatnot, they actually tend to become more aggressive and not less aggressive. The current theory of why that is that by bringing up all of these anger emotions, the person remembers why they're angry, and that makes them even more angry. Okay. Does it work with other things like depression and anxiety and even trauma experiences and whatnot? The answer is that there is some efficacy to cathartic release. Okay. So, for example, about 80% of people who go into psychotherapy or counseling, 80% of them don't return after the first or second session. Okay. And researchers have wanted to know, why is there such a huge dropout rate after about the first or second? Is it that there's something wrong with the therapist? Is there something wrong with the treatment? Is there other reasons why they just decided not to come? And it was interestingly because we went back and we found those who we could interview and ask, why didn't you return to treatment? And again, we're going to use that 80% mark. Greater than 80% of individuals who don't return after the first or second session state that they felt a relief of their symptoms. And we got really curious. Well, how in just one or two sessions of treatment can someone feel relief of their symptoms? And the answer came to, for a majority of those individuals, it was the first time in their life that someone said, I am here to listen to you. Anything you say to me in these four walls will be kept confidential. And then they give the, disclaimer, except for child abuse or, blah, 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 the state requirements and federal requirements. But anything you tell me, I can't tell another soul. And anything you say, I am listening to. I'm here to listen to you. And for a lot of individuals suffering from different types of disorders, it is the first time someone has ever listened to them in a non-judgmental way where they don't have to worry that the whole community is going to know about it. And it's the first time that they were just able to release all of those things that have been kept inside. Okay. So does cathartic release work for other disorders outside of anger and those? The answer is that there's a growing evidence that yes, it does. But I will say that relief can tend to be short term without ongoing types of treatment. And so while it's good in a kind of short term relief method for someone suffering from a disorder, does it have a long term efficacy? The growing literature suggests that it doesn't, but at least it's helping people, at least in the short run, for things. Okay. So this is how, again, this humor theory has influenced kind of our modern ideas of things like counseling and therapy, things like anger management and whatnot, which it didn't pan out well for, and those types of things. Okay. All right, I am going to actually stop here because this gets into another modern idea of expert witnesses and expert ideas with the witch hunt. So I'm going to stop my sharing and I'm going to stop my recording.